Thank you and good morning. I'd like to welcome everybody. I'd also like to introduce Dr. Charles Bailey, our first speaker for the day. Dr. Bailey is a gentleman that I've come to know in collaborating with him on the PedsNet project. He has been very helpful in sharing his knowledge as we build out our informatics program. Dr. Bailey is an assistant professor of clinical pediatrics at the University of Pennsylvania School of Medicine from 2008 to present. Dr. Bailey earned his medical degree from the University of Pennsylvania School of Medicine, along with his PhD in cellular and molecular biology from the University of Pennsylvania in 1998. He's also a fellow graduate of Washington University, class of 1986. And Dr. Bailey is a member of the Division of Oncology and Hematology at Children's Hospital Philadelphia. His clinical focus is on leukemia and lymphoma, and particularly in acute lymphoblastic leukemia. He also works on improving quality of supporting care for children with cancer. His research centers on the development of learning health systems, which are based on the principle that every patient receives care. We must use what we learn to improve our ability to care for their children. Dr. Bailey's work includes creating ways to share data across hospitals, to recognize the clinical implications of information gathered from different sources, and to provide support to clinicians in using this information more effectively. His presentation today is titled, "The EHR Design is a Building Block for a Learning Health System." Please join me in welcoming Dr. Bailey as our first speaker at the third annual Clinical Informatics Symposium. Thank you.
All right, good morning, and thank you very much for taking the time to join us as well. It's a real privilege to be able to talk with you folks. It's also nice to be back in St. Louis. We spent the evening reminiscing about all of the things that weren't here when I was at WashU. Right. So I have the happy situation of being the first speaker, so no one will have said what I'm about to say. But I'm also in the position of laying the groundwork, so this is going to be a bit of a rapid tour through some of the principles behind our Learning Health Systems projects, and it will be somewhat of a mix of informatics, engineering, and public policy. But I do want to start with some of the housekeeping quickly. I have no disclosures. I will mention some off-label uses of medications, since most of what we do, certainly almost all of what we do in pediatric oncology, is not labeled. That's common for pediatrics. More importantly than the disclosures, I want to start off with the acknowledgments. Right? We're talking about research that kind of acquires the informal term big data. And one of the things that hides behind the label big data is, in order to do any of this work, you really need big teams and big collaborations. And it's a model of science that I think is relatively familiar to some of our colleagues in physics and economics, is growing in the biomedical world, but is still fairly new. And I think I want to be careful that this doesn't get lost. So the work I'm going to talk to you about is primarily due to the contributions of the 4.5 million children and their families who have donated their data to us and have entrusted us to make good use of that data. It is also due to the ongoing work of folks at the 8 sites who currently contribute data to the PedsNet collaborative. There we go. And to the good folks at CHOP in the Data Coordinating Center for PedsNet who try to make sense of all of these piles of information. And then finally, I'll talk about some specific projects, and wanted to acknowledge the folks who had worked on the analytic teams for those. All right, having set the context, let me briefly summarize where I'd like to go. I want to talk a little bit about why we do what we do. So what makes up a learning health system, and why do we structure what we do around that? Discuss in particular the role of electronic health records and clinically acquired data in building learning health systems and enabling research and quality improvement, and look at some of what we've done as examples of first steps. We often refer to ourselves as being in the toddlerhood of the learning health system. So I'm not setting these up as ideal examples of ways to conduct research, but I'm setting these up as ways we need to wade into the data and wade into the methods to learn how to learn. All right, so I want to start with the notion of learning health systems, and I want to take some of the principles from one of the early fathers of biomedical informatics. So this is Hippocrates of Chios, better known perhaps for his role in organizing the practice of medicine in ancient Greece and in laying down some foundational principles of medical ethics. But in fact, that's exactly the crossroads I want to highlight here. So among the principles that are laid out in the Hippocratic Oath that comes down to us through lots of retranslations and recensions are two key points, right? The first thing is it's our job as clinicians, as healthcare professionals, as informaticians to take care of our patients and to do our best in taking care of our patients. It's not enough to just show up. It's not enough to know that we know a lot about things. Part of what we commit to in entering this enterprise is that it's a lifelong process of improving what we do. And that's actually baked right into these foundational principles of ethics. In fact, I've actually put them up here in reverse order. If you look at the way that Hippocrates laid out his principles of medicine, the first thing he's saying is that part of what you need to do is to teach, and part of what you need to know to teach is how to learn. Right? So while we think of Hippocrates more as a kind of knowledge management guy in the informatics constellation, these ethical principles drive a lot of what I'm going to be talking about in the learning health system arena. Right? Now, the name learning health system, which is probably familiar to most folks in the room here, is a term that's kind of gotten wider adoption through a series of documents and workshops that the Institute of Medicine has disseminated since about 2008. And what's different or what's novel about the learning health system is not perhaps the notion that every time we meet a patient, we should be using that not just to take care of the patient, but to learn how to take better care of the next patient or how to take better care of that patient the next time. But the key principle here from an informatics perspective is it's the system, right? That it's a good start if I learn from the patient. It's a good start if I teach you what I learn, but I'm still not doing what I need to be doing. We need to actually build the system so that it helps us to learn and it learns along with us, right? And this is not just a technical principle, as I pointed out by reference to Hippocrates. This is actually a key part of the underlying trust that patients put in us. When my patient comes to see me, they expect not only that I be a reasonably knowledgeable oncologist, and not only that I know what the current protocol for treating their acute lymphoblastic leukemia, and now you know, Scott, why we call it ALL, but that I learn from them. Whether or not they have sat down and signed a piece of paper that says I'm going to be part of a clinical trial, the expectation is if something happens to them, I'll know how to stop that next time, or I'll know how to improve from that next time. So we need to build that into our systems, and one of those systems is the electronic health records. In particular, I want to think a little bit about how electronic health records and clinical data fit into this learning health model. Right? One of the things I'm going to continue to come back to is with the current adoption of EHRs, this really provides us with a uniquely broad window into the population we take care of, right? It's a sort of final common pathway for a lot of disciplines and contexts of care. And it is becoming the source of clinical truth, right? One of the things we have struggled with in clinical research and in clinical learning is lots of information is locked up, not just in my mind, but in my chicken scratch, right? Now this becomes the source of truth. Sometimes we do a good job with that, sometimes not so good a job. But what we do is get all kinds of data together, and it makes it available about patients. I also want to mention that we're talking mostly now about what clinicians do. We're getting closer and closer to the point where patients are a more active part of this dialogue about their health care and about what goes on outside the hospital. Right? That's not to say it's all flowery meadows, right? So there are issues right up front with the EHR that you need to take into account as you're designing a particular implementation, right? The first, and one of the things to remember is that the thing that drives EHR implementation and the thing that keeps companies like Epic and Sunrise in business is the business of delivering care to patients, is the scheduling, the patient flow, the ordering of the medications. And we need to be aware that that clinical care is what shapes the data we collect and account for that in the way we learn from it. In particular, although it's not in my chicken scratch anymore, there's a lot of information that's locked up in unstructured data, right? And the The reflex as we start to use EHRs is to use them as a recording tool so that you move the free text off a piece of paper into a screen in front of you, but we need to think about what that does to the information, right? The other thing we need to be aware of is there are a bunch of technical barriers because it is Epic's job to stay in business and support Epic's customers. It's GE's job to stay in business and support Centricity's customers, and so on and so on. And on the process of getting there, there's a fair amount of variation in the way we represent information in different situations and the way we present that to the user, which obviously then affects how the user is going to interact with the system and what information they're willing to collect. Okay? It's getting better as there's more collaboration. It's getting better as at a health system and at a governmental level we encourage, nudge, standards for interoperation, but still a lot of work to be done. So in framing that, I want to think about the structure of the information that gets into the data model in a kind of simple-minded way. So what I've done is I've laid out a horizontal axis here, which has to do with how much we understand about the words I'm using. Is this an idiosyncratic term that I use to describe a patient, or is it a standard term, and when I say amoxicillin, everybody knows what I'm talking about? And on this axis, what I'm asking is, how structured is the information? How easy is it to get my hands on it? What I would love in building learning health systems is for everything to be up in this quadrant. Nice and discrete, I know what that fact means, and we all agree on the meaning of the word, right? What happens a lot of the time, particularly as we get started, is data lives down in this quadrant, where I say things in my own way to remind myself of what's going on, and it's locked up in a blob of text. So part of our job in the learning health systems world is to drive as much of the data as we can into at least the upper half of this graph, to turn it into information that becomes usable, either by changing the way we capture it or by getting better at picking it out of the big piles of text that we're currently dealing with. All right, so let's talk about how you learn from those sorts of routine data. Right? I mentioned one of the real opportunities here is the potential to evaluate a large population computationally. Now, that's methodologically a nice thing because on the input side, it can reduce selection bias. Now, you don't have to worry about who I took the time to fill out a case report form on. It also allows you to survey the whole population, so you eliminate sampling biases. On the output side, it gives you the opportunity to detect rare signals as long as you have a good way to manage the noise around them. The other thing I want to highlight here is we need to remember we have lots of primary data, right? So we're not just relying on the conclusion I drew about the patient. We can see the information I used to draw that conclusion. And one of the questions we need to ask ourselves is, we're used to operating on coded diagnoses. Do we need to do that? Is there a better way I can measure the primary outcome? Or we're used to operating on billed claims. Is that really the right way to look at things? Can I look at a different granularity or a different structure to the information that will inform my study design in a better way than seeing what made it through to a bill? All right. The third thing I want to say, and this is perhaps the most important point I'll make, is make lots of friends. Right. Part of big science or team science is you need lots of perspectives on the data. And in that vein, what I want to talk a little bit about now is that the collaboration that we are a part of, along with St. Louis Children's, in the PedsNet network. So this is a concept that came together after a 2009 IOM roundtable on what it would take to create learning health systems in pediatrics and what were the challenges that were different in trying to address the health care of children. Right? It started as a 6-institution collaboration. I'm really happy, both as a remote WashU alum and for the minds of the folks who are in this, that St. Louis has been part of this collaboration from the beginning. Currently has 8 institutions and is part of PCORI's nationwide distributed research network. So if you look at the current composition of PedsNet, we have a constellation of mostly large, mostly urban pediatric institutions, including you folks, as I mentioned, for which we are very grateful. So we have some biases around academic health centers, but we also have a fairly broad national perspective, right? In that collaboration, we're able to share data about the way we take care of our patients. Equally importantly, we're able to share structures about how we construct research, how we address regulatory issues like IRB protocol reviews or contracting, that sort of thing, and how we design studies to make them work. Right? Finally, particularly as we moved into the sort of PCORNet-supported era, we've gotten better and better about getting patients and families into the conversation, not just about what the research we did means for them, but about what the research we need to be doing is. All right, so let's start with the data. This gives you an idea of where across the nation PedsNet patients are found. Darker here is more patients, and you can see, in the catchment areas of each institution, we tend to have a fairly dense population, but we actually spread out, and at this point, we're collecting data from a sort of fair chunk of the nation, right? A note on our process: each hospital collects information from their source systems, EHRs, billing data, data warehouses, things like that. It comes to the data coordinating center at CHOP, where there's a fairly extensive, we call it a quality assurance program. Really, it's more a data characterization program, and I'll talk a bit more about it later. And then the data coordinating center tries to make things easier for everyone by kind of fronting the data in a way that is more easily accessible for research. We will briefly talk about the data models we're using here, both of which are intended to try to make the surface of the data a little bit more level. So what this process yields is, at the moment, these data are a couple weeks old, information of about 4.7 million children over about 100 million visits, and we've got about 700 million different facts about these patients. Part of why we have a DCC to try to keep track of this. But the point to make here is, I talked about large population size. So we have about 4% of the nation's children represented in this network, which gives us a unique opportunity to look at the way these children grow, what their health is like, and how we deliver health care to them. Which takes me back to some of our founding fathers of medical informatics. Anyone want to guess at who this gentleman is? Close. I was hoping if I stole a modern patient. So this is a picture of Socrates, and if you've read about Socrates all that much, you know he was a man who liked to talk. The painter here, represented him just about minutes before he died, declaiming the injustice of his death. So one of the fundamental phrases that comes down from his era, it's often attributed to him, although the attribution is not very clear, is the notion that you should know yourself, right? Gnothis auton, for those of you who speak Greek, right? The informatics equivalent in equally unintelligible Greek, right? Gnothi de domina sas, right? Know thy data. So the key here is we don't get to control the data that we work on, so we need to know how those data behave. This is also a subtle hint that you should use the right terminology. Because if I say to you, gnothi de domina sas, you look at me and say, what? Right? But if I translate it into a terminology that's up in the upper right-hand corner of that graph, we have a much better understanding of what's going on. And this is what's behind the big data characterization and data standardization process. Right? So when I talk about our data quality program, I talk about trying to assess how well the data work for us on a number of dimensions. You can read them up here, but in essence, we're doing some traditional work that says, how accurately did everyone get the data to us? How accurately does what's in the data coordinating center represent what was in the source system? How often, when you want to say the same thing today and 6 months from now, do you say it in the same way? How often does our hospital change our terminology? That sort of thing. How often are the data correct? Where we can look to an external source about the population, are we reflecting that population? What are our biases? And how much information can we collect about a particular fact? The idea here is to assess not just how good was the process of moving the data around, but how useful will these data be to actually learn things about patients. And if you look at our results, it shows we've got a lot of work to do, right? So this is a summary of about 580 data quality issues that have been identified over the year that we've been sharing data. In particular, I want to point out a couple of features. These dark blue bars are what we call ETL errors, so mistakes in the process of moving the data around. Started out as a major contributor, getting better as time goes by, and importantly, those are fixable. So if it's a problem today, it will not be a problem 6 months from now. But the other thing to point out is about half of what we call data quality issues are actually simply characteristics of the data, right? We don't collect gestational age. The coding system we use for ethnicity is not the same as the one you're using, and it's very hard to map our overlapping categories to your overlapping categories. So these things are going to stay with us, and we need to be alert to them as time goes by. So how can we approach that? Let's look at some use cases here, all right? So I'm going to pick another early father of informatics, Andreas Vesalius, so a 16th century physician who was one of the major contributors to organizing what we know about anatomy and surgery. So one of his oft-quoted aphorisms was, "I'm not accustomed to saying anything once or twice." Now imagine for him, this meant having to go find more bodies to look at. Our job is a little bit easier here, but we need to be careful that we avoid the sentinel problem, right? So I'm going to look at a really simple case. This is where we took 6 of the PedsNet institutions. We collected outpatient data on a variety of information, including height and weight measurements, and we started to ask, what do we know and what do we say about obesity? So a couple of things that this really simple exercise drove home. This line here is at 6,000. Right? So for every month of age, we have more than 6,000 children who have told us what their body mass index is. If we want to know about the population prevalence of obesity or malnutrition or what linear growth looks like, we have an incredibly rich data set that's been accumulated here just because kids come to their doctors to get their vaccinations and get their checkups and get their sports physicals. How does that look? Are the data any good? Because we weren't capturing them for research. So what you see here is an internal standardization. Each curve is how the data are distributed for each site. And you can see across those 6 sites, they line up pretty nicely. A little hard to pick out in this multicolored graph, but right at the bottom here is a black line. That's what the National Health and Nutrition Examination Survey or Evaluation Survey, the annual CDC-run, very carefully measured and stratified survey of growth in the U.S., predicts the curves ought to look like. So we're actually doing pretty good in the pediatrician's office. And if you use those data to try to do things like construct the growth curves we use all the time, here's what you get. The green plot here is what NHANES generates. So that's what's behind the growth charts those of you who are pediatricians use in the office every day. About 30 kids go into each point on this chart, and you can see, particularly as the kids get older and people hit puberty at different times, there's a lot of hysteresis. So our estimates for those kids have pretty wide error bars around them. The red dots here are what the pediatrician's offices tell us, right? And right down the line, in the right place, no hysteresis. Once you've got 6,000 measurements to work from, you can get pretty good estimates of what kids are doing. So this was without anybody lifting a finger to capture research data. What does it mean? So NHANES each year publishes estimates of the prevalence of obesity and overweight in the population. So we asked, what if PedsNet did that? We divided kids by age band, and you can look at the prevalences of obesity: 18%, 18%, 19%, 18%, 20%, 20%. We're right on with this very careful, very well thought out and very expensive survey method is using to generate 2-year moving averages, right? We're in a position where if we needed to, we could generate 6-month moving averages and we'd be fairly accurate. Know thy data. A little under 20% of the NHANES sample is toddlers. A little under 30% of our sample is toddlers. Most of our kids live in an urban or suburban environment. NHANES averages out so that there's more of a rural contribution. Not surprisingly, more of our toddlers are overweight and obese than NHANES. Right? So I'm not suggesting that things like EHR data capture should replace weighted surveys. I'm suggesting that they're complementary methods. We learn a lot just from taking care of kids, and we need to know if, for instance, we're making some sort of intervention that's designed to improve overweight and obesity, what the effectiveness that is on a much shorter time scale than 2-year moving averages. Okay. We also asked, what do we think about obesity? So what you're seeing here is a plot of how often, for a child we knew from looking at their body mass index was obese, did the doctor they saw write it down. We'll exempt the tall bar, which is weight management clinics. So those are kids who are generally very obese and are referred specifically for weight management. Nobody else, not the pediatricians, not the gastroenterologists, not the endocrinologists, not the oncologists, certainly not the surgeons, did better than 1 in 3. So that means a couple of things. One, if we're paying attention to obesity, we're not writing it down, right? And there are some administrative reasons that might be the case. Two, from my perspective as an informatician, if I had started out with the traditional administrative data set, I just missed or misclassified 80% of my cases. Know when your primary data is going to help you. The other thing you can do is when you have 600,000 kids to look at, you can say, what are the comorbidities associated with obesity? Sure, we find the things people are used to, things like type 2 diabetes, fatty liver, sleep disorders, that sort of thing. But we can also redetect, again in this very low-effort sample, associations between leukemia and obesity. Not a surprise, we have to give lots of steroids to treat leukemia. Between chromosomal anomalies and obesity, between neuromuscular disorders and obesity, and other things that we wouldn't have expected. Again, I don't hold these out as true or causal, but they get you started on thinking about the problem in a different way for different populations than you would have if you had 30 children for each data point. Okay. That's what's going on at baseline. Let's look at what happens when we try to take care of patients. So I've moved up a little. This is William Osler, 19th century man who clearly must have known somebody was going to quote him because it seems about every third sentence he spoke gets written down and quoted. So one of his statements, perhaps a little more forceful in the 19th century, but still with its truth, is one of the first duties of a physician is to educate the population not to take medicine. So one of the things we as pediatricians, particularly in primary care, wrestle with is trying to figure out when children should and should not take antibiotics, which turn out to be the most commonly prescribed medication in the first 2 years of life. Right? So we asked ourselves, do antibiotics affect this obesity problem we have? Well, what we want to know is who gets them, why do they get them, what actually is an antibiotic, what drugs should we be paying attention to? Right, so we knew going in what our research questions were. Now the question is, how does that connect to the data? And here I want to make a brief detour into the notion of terminologies. Mike is going to talk about this in much more detail later, so I am just scratching the surface here. But if you live in the IT and EHR world, you have probably tripped over a bunch of these icons in your daily work. Right? And our goal here is to try to organize the results not just into the local codes that make it possible for our lab information system to talk to our EHR, to talk to our billing system, or me to look at a result and say, oh, I know what that assay was, but what are the ways we can describe these so that we can exchange information, right? And the issue is some of these names aren't as easy as they might sound. So I was talking about kids getting antibiotics. The most common reason that a child gets an antibiotic is for ear infections, otitis media and Dr. Ease. So I walked up to the database and I said, okay, I want to know about otitis media. And this is one of the tools that we have in the DCC for looking at how terms are expressed. And it said, okay, I'll tell you about that. There are 258 different ways. Which one do you want to know about, buddy? Right? And part of what this is highlighting is the variability in organized terminologies. None of these, I didn't make any of these up. These are all in healthcare terminologies. Part of what this is doing is highlighting the fact that it's worth our effort on the front end to take these 258 and organize them in a way that I can ask one question and I'll get to all of those data. Right? Even if I stick with the blue terms here and ask just about what we call standardized live terminologies, what you see is, okay, I've got otitis media. That's got a couple of relatives. Let me pick just the acute cases, because those are the ones that might get antibiotics. There are still 15 variations in the way that gets coded. Right? So again, what you want to do is use your data model and use your terminologies to build a hierarchy that lets me say, I want to know about all of these acute otitis medias. All right, I want to know about antibiotics. Well, I know amoxicillin is an antibiotic. Let me ask about that. So I ask RX Norm about amoxicillin. And this is probably unreadable from more than 10 feet away. But the point here is that down here are the drugs that kids actually take, right? And there are about 80 of them, right, that fall into different manufacturer groups, that fall into different formulations, that fall into different classes, all of which could respond to my question about amoxicillin. And again, this information is not random, it's organized. So, I start here with amoxicillin. I know that's a penicillin. I know that's a kind of antibiotic, and so on and so on. So maybe what I want to be asking about is this term antibacterials for systemic use. And if I've organized my data in the right way, it will know to get me from that general term to some of these specifics, or at least give me a leg up in getting there. So now the questions don't become who gets antibiotics. It's what socio-demographic data do I have about the population of kids that I can use to adjust for confounders? Why do they get them? What are the diagnostic terms that are associated with a visit where antibiotics were prescribed? What's an antibiotic? Well, which of those branded dose packs that the patient actually takes home correspond to the name amoxicillin. And what we see from that is in a sample of about 65,000 kids, lots of kids get antibiotics. So these are kids who got any antibiotics. The little dark red bar at the top are kids who have gotten 4 or more. The dark blue bottom at the bottom are kids who made it to 2 without getting any antibiotics. And you see they're only about a quarter of the population. More kids get narrow-spectrum drugs than broad-spectrum drugs. That warms my heart as a pediatrician. It really warms my heart as an oncologist because, unfortunately, I have to suppress immune systems to treat cancer, and I hate resistant bacteria. Right? So less antibiotics are better. What happens when you take antibiotics? Well, if I look at how many antibiotics you get, the more likely you are by the time you're in school to be obese. Does anything we do affect that? Turns out, yes. If I stick to narrow-spectrum antibiotics, right, the AAP, the American Academy of Pediatrics, the American Academy of Family Physicians, the Infectious Disease Society of America, the Pediatric Infectious Disease Society has said for a decade, when somebody comes to you with an ear infection, if they need antibiotics at all, you should give them a narrow-spectrum drug. Still, about a third of what we prescribe are broad-spectrum antibiotics because they're newer, they're shinier, you take them once a day, variety of other reasons. If I stick to those narrow-spectrum antibiotics, no matter how often I have to treat an ear infection, your risk of obesity doesn't go up. If I'm using the broad-spectrum antibiotics, here's the whole motion in the curve, right? So that's what's driving the increased risk of obesity in kids. Here's a factor we can modify, right? Here's a conversation we can have with families and with physicians about why you're picking the antibiotic you're picking. Again, from the data we collected when someone came to us with an ear infection. All right, let me look at one more use case. We not only want to know what the downside of what we're doing, but we also want to know the upside, right? So this is Galen, 2nd century Roman writer about medication, had a couple of interesting things to say about drug effectiveness studies, right? So here's his report on the effectiveness of a particular drug, right? All who drink this remedy recover in a short time. Tremendously effective drug, but we need to do drug safety surveillance, except those whom it doesn't help, who all die. Okay, maybe we need to rethink the value of this drug. So part of what we wanted to ask was, in this huge body of observational data, what can we learn about new drugs, right? We're very used to doing randomized clinical trials. It's an excellent method. It controls very, very well for a lot of potential confounders, and it helps isolate the effect that we want to study. It's also incredibly expensive. To look at 200 or 300 kids, we're talking about $500,000 to $750,000. And there's a well-known clinical trial enrollment effect. Your care changes even if you're on the placebo arm. This has actually been in the news for a couple of days, right? Because simply being in a clinical trial changes the way we deliver care to you. So we learn a lot about efficacy in a randomized clinical trial. We learn maybe a little bit less about how it works in the real world. But what's happening in the real world is people are doing trials all the time. So what we did was we worked with a registry called Improve Care Now that follows children with inflammatory bowel disease, and those kids get treatment as determined by their clinicians based on their symptoms. We collect information about what happens at their regular clinical visits and what the severity of their symptoms are, and every day somebody decides, I'm going to start a biological agent, or I'm going to start a non-biological agent, or I'm going to start a steroid, and these clinical trials are going on. The problem is that they're scattered all over the place. So if we want to study them, we have to look like a clinical trial and ask what happens, not in calendar time, but in drug time. And so what we do is line all of these people up in the observational data, look at when you started the drug and what happened afterwards, right? And follow them out just as though we were conducting a clinical trial, accepting those biases. And I also want to note for the methodologists here, we acknowledge, we certainly understand that there is a right censoring issue here as well, because we can't say you come back on day 90 or day 180 plus or minus 5. You come back when you come back, and there are ways to account for that. So we actually compared what we would find looking at TNF-alpha antagonists in the gold bars to what a randomized clinical trial of about 200 kids found. A couple of things. No significant difference between our conclusions and their conclusions regarding efficacy, but I think meaningful that we're a little bit below what the clinical trial shows on both the ability to improve your symptoms and the ability to get you into a sustained remission, right? And that partly reflects what goes on in the real world, where we don't have quite as controlled a situation. What it means is that, again, we can use these data aware of the limitations, to generate the kind of outcome curves that we're used to looking at. This is a survival curve for getting into remission for your IBD. Again, just from what happens when you come to see your gastroenterologist, because the health record was designed to collect the information and because we're able to figure out how to organize that information post hoc. All right, so those give you some examples of the kinds of things we can do. What you want to do in order to accomplish this is actually get your hands on the data you need, all right? So I don't want to be too biased towards physicians here. Lots of other people have had good things to say about informatics. Florence Nightingale's notion of how to organize not just your hospital, but your data capture, right? We're very good about saying, here's a form you have to fill out. To be compliant, you have to complete this. Here's an alert. We won't let you past it. It's actually a lot easier to catch flies with honey. So things you can do. One of the things that we've done for this Improved Care Now network is there's now a form in the EHR that physicians fill out or nurses fill out that describes a patient's symptom. Why should they take the time to fill that out? Because if you fill that out for us, we write your note for you, and we write a letter to the referring physician using the data, and we take this data and feed it back to the collaborative so you don't have to fill out a CRF, right? So there needs to be a value for the person recording the data, not just the person doing the research. In addition to filling out case report forms, you can say, I'm going to limit the data you want to collect to just the data I need to know. This is what you need to know to decide if someone with an ear infection needs antibiotics. And if you'll tell me that, I'll tell you what antibiotic is recommended for this kid. Don't pick that broad-spectrum drug, okay? And the next time they come back, I'll tell you everything you want to know about what's been going on with their ears for the past year. So you can figure out whether this kid whom you're seeing while you're covering for a colleague has a typical viral ear infection, or you need to start thinking, does this patient need to see an ENT doc or need to get their hearing tested, right? And I'll write your note for you and write the orders and tell the patients what's going on and that sort of stuff. The alternative to this is I put it in a note and you have to parse it out. So this reproduced horribly, but this is the amount of code it takes us to dip into my note about the physical exam and read the line about what was going on in your ears. I would much rather you checked a couple of boxes, and I'll write it into the note for you. Okay, so let me bring it home. I had to have one slide that had no words in the title because this is about informatics and acronyms rule. So how then do we want to use the electronic health record specifically to build learning health systems? Know that there's a lot of primary data in there that we want to make use of, and understand how you can use that. Think about terminologies. Think about where you can get people to record things in a lingua franca instead of in their own idiosyncratic notion, or where you have to do some of both, right? Embrace the real world. This is not a randomized clinical trial, but this is where kids are healthy, get sick, grow up, get care, know what's going on when we're actually taking care of kids. And certainly don't do it on your own, right? Work with lots of people. PedsNet is about that. PedsNet is one of 20 things each of our hospitals is involved in. We need to get better and better, and we need to get past the notion that the information we have about our patients is secret, is something that for legal reasons or clinical reasons or business reasons we can't share, because the patients don't want you publishing the details of their health record in the Post-Dispatch, right? But they also don't want to think, my kid got sick, my kid has a disability, my kid was in the hospital, and you could have prevented that because somebody down the street or across the nation knew that was going to happen, but you didn't talk to each other. Right? And then finally, remember that taking care of kids has to be the same thing as learning how to take care of kids the next time, right? We know this is an uncertain world. Again, I said every third sentence from William Osler is quotable, right? Famous for saying, medicine is a science of uncertainty. There is no way I'm going to understand all the complexities of the biology that is me or my patient. And an art of probability. Every decision I make is my best estimate of what's going to work for them. I know that uncertainty is there, but this is not the black box I want. It doesn't help if I say to the patient, and then I made a decision, I can't tell you why. All right, thank you very much for taking the time to listen. I'd be happy to take any questions. Yeah, I think that's a great question, and if I had a great answer, it'd be in JAMA. I think that's a very real issue. I think we need to do three things. The first is we need to realize when we need to tell the story and when we don't. I'm as guilty of that as anybody, right? We all came up in medicine in a narrative culture, and we learned from the first moment we started taking care of patients that it's about recording a story because there's some detail in there that might be significant. So we need to know when it is and when it isn't. We need to use terminologies in a way that are easy to get to. I didn't go into it here, but the human-computer interaction around most electronic health records is awful, and people in almost any other field will tell you that. One of the ways it's awful is if I want to check a box, it's over here. If I want to write a sentence, it's over there, and I'm only going to do one because I've only got time to do one. We need to unify that information, and we need to make our terminologies good enough to express the detail we need to know. We need to record most of the time. Okay? So those are the pieces of pie in the sky. All right, well, thank you. A sure sign I put everybody to sleep.